Welcome everyone to this meeting of the Health Scrutiny Committee here at Leicestershire County Council. Today's meeting, which is the obviously the 17th of January's meeting, we are going to start by welcoming all of our members here. We do have an apology today from Mr. Pendleton, and we have Mr. Bannister who's joining us as a substitute, so welcome Mr. Bannister. Otherwise, I think we're all here and ready. So welcome also to Mrs. Richardson, who's our lead member for health, and obviously to our officers as well. I'll introduce those as the items come up when we get to them. So I think that's probably all of our bits and pieces dealt with. Obviously, as usual, this meeting is being broadcast through our YouTube channel. And just remind you also about the buttons for the intercom. I know everyone's very, very used to them by now, but the cameras don't work properly unless the red light's on when you're talking, so you're not going to get broadcast to the world unless you hit the button to get the red light on. And likewise, unless you desperately want the limelight, if you could turn the red button or the button off so the red light goes off, otherwise the camera stays with you. And I appreciate you want everyone else to actually be seen rather than you. So hopefully it should work swiftly and smoothly. So we're on to item 1, which is the minutes of the meeting held on the 1st of November 2021. I wasn't present at that meeting. Mr. Seaton was in the chair, so hopefully we can have a proposer and seconder that those were appropriate. Brilliant, Mr. Harrison and also Mr. Hills. Thank you very much. And pass my thanks also to Mr. Seaton for taking that meeting, which I know had many, many things on the agenda, and I know was handled swiftly and smoothly as well. So thank you very much. Item 2, we have question time. We have not received any questions from members of the public. However, on item 3, questions asked by members under Standing Order 7.3 and 7.5, we have received a question from Mrs. Amanda Hack, who's on the screen in front of me. Welcome, Amanda. The question relates to elderly people and community hospitals. Mrs. Hack has been provided with a written answer from the health team at the NHS, and that has been published on the council's website. Now, we haven't got anyone from the NHS here to provide you with any verbal answer to any follow-up question that you wish to ask Mrs. Hack, but obviously, if you want to say anything now, then by all means you can do. Alternatively, you're very welcome to put any follow-on comments through to us, and we'll obviously make sure that they get responded to directly from the NHS colleagues. Over to you, Mr. Hack.
Thank you, Chair, and nice to see everybody. Happy New Year. I don't know if that's a bit late now, but the question in the main was just very much around communication with families, and in question 3 and 4, and I think my sort of follow-up supplementary, it links those two together, is very much about how important families are to managing long-term illnesses and keeping those patients well once they're released from hospital. Both cases that I've raised actually include the patient both with dementia diagnosis. So there was a question around the patient themselves might be informed if the cottage hospital or community hospital had changed. So it's very much around making sure that the hospital keeps the families informed, and what work were they doing to deal with cases where this hadn't been the case.
Okay, thank you very much, Ms. Hack. I mean, by all means, obviously, if there's a specific answer that you're looking for, by all means, please sort of put it through as an email to Ewan, who will be able to try and get a further response from the NHS, if that's okay.
Lovely, thank you, Chair.
Okay, thank you very much. So we're now on to item 4, which is to advise of any other items which the chair has decided to take as urgent elsewhere on the agenda, and there aren't any. Item 5, declarations of interest, respect to the agenda. So can I ask? Okay, so I was going to say, so Mr. Newton, this is your standing item of interest, so that's fine. Thank you very much. So are there any others? Mr. Bannister.
Yes, thank you, Chairman. My wife did work for the NHS, employed as a senior radiographer by the UHL NHS Trust. She retired yesterday. But given the close proximity of her employment to this meeting, I thought I'd better make that declaration in any event.
Thank you very much, Mr. Bannister. This is my favourite comment, my mother-in-law's famous comment, which is, was it retired? It would come to me, but it will come back to me. Mrs. Eaton first.
I declare an interest in my daughter as a sister nurse at the LH at the General Hospital. Thank you.
Okay, thank you very much. I still can't remember what the phrase is now. My mother-in-law comes up with some amazing phrases sometimes, so I'll remember it by the end of the meeting. Very appropriate to you in that case, Mr. Benson. Right, thank you very much. Mrs. Eaton, thank you very much for that one. No others, so that's fine in that case. Retired for life, not for lunch. That was the expression I was trying to think of. Okay, so we're on to declarations of the party whip, item 6. Are there any declarations? Nope. Okay, so we're on to item 7, presentation of petitions under standing order. Haven't received any petitions, so we're now on to the main 3 items on the agenda. Item 8, public health medium-term financial strategy. So sitting in front of us, we have Mike Sandys, who's our Director of Public Health. Obviously, Mrs. Richardson, who I've already introduced, is the Cabinet Lead for Health, and also supported by Adrian Allen, who's the Assistant Director of Public Health. And we have online. Oh yes, we have online Sam Barrett, who's a Finance Business Partner. So welcome to our 3 officers in particular. So you have received, obviously, not only the papers, which we always take as read, but you have also received an additional sheet which has 4 sections. We'll be taking the questions on this report in the order set out in that additional sheet to make it quite clear. So can you make sure that any questions that you have are reserved under the particular section of the 4 sections that we have on that sheet. So first off, I'm going to ask Mike whether there are any points he and his team wish to raise, obviously taking the paper as read, before we actually start on any of the questions.
Yeah, thank you, Chair. I mean, I will take the paper as read. I guess overall, some of you on scrutiny will be very well aware of this, but just to sort of recap, as it says, it provides information on the MTFS as it relates to public health. Always worthwhile remembering that public health is funded by means of a ring-fence grant from the Department of Health and Social Care, which is to be used on the exercising of the public health functions that the local authority is responsible for. So in terms of the MTFS, there's probably 2 things, one of which MTFS related, one not. So why do we have budget cuts, budget redesigns within public health? Twofold, one of which is the budget, the grant allocation hasn't increased in line with inflation. So we've had significant cost pressures, notably within, say, NHS pay awards. So we have our own kind of smoke to consume every year within the grant. And then what we try and do within the confines of public health grant conditions and establishing proper assurance processes to assure OHID, the Office of Health Improvement and Disparities, that we're spending the grant appropriately, is to try and stretch the grant as far as we can so we can spend it on allowable expenditure in other parts of the council where they can contribute additionality and public health added value, if you like. So hope that makes sense. So the line in the paper, which I think is the where is it? The difference between the public health grant of 27,444, £27,440,000, and the total that's detailed is 24838. That £2.6 million is the amount of money we're trying to free up within the public health grant to spend on allowable expenditure elsewhere in the authority.
Okay, thank you very much. Anyone else want to say anything before we start? No. Okay. So what I'm going to do, thank you very much for that, Mike. What we're going to do is take obviously the 4 sections. Section 1 deals with service transformation and proposed revenue budget, which is paragraphs 5 to 10 on pages 15 to 17, and also Appendix A, which is on page 23. So, Mrs. Newton, is your question related to those paragraphs?
My question is probably a bit more generic, so if I ask, could we take it then? It was really, the public out there really don't know what we do in terms of public health, and I think we really need to sell ourselves better than what we're doing. So my question really is, can we more or less enforce and let people know what is the added value of public health in terms of its contribution, in terms of helping to reduce the causes of ill health and health inequalities, and also improving people's health and well-being. It's really letting people know how much we're doing and if they what they could do as well to help too. Thank you. It's a generic question. Thank you.
Mr. Newton, do you just want to switch your microphone off?
Oh,
there you go, cheers. I think that's a good one. I mean, again, we have now been in the local authority for 11 years in April when we transferred over from the NHS. I suspect a great many people know that don't know that we are actually the responsible body for commissioning sexual health services, which all come with an NHS logo. That large sum of money in children's public health 0 to 19, the 8.759 million quid in table 2 is essentially the budget for, amongst other things, health visitors. When a health visitor goes out to a newborn, it's the local authority of the public health grant that commissions that and pays for it. NHS health checks would be another one. So there's a large amount. Essentially, we are the kind of part of the NHS that actually sits with local authorities. And I don't think people would know that. And then in addition to that, not the single statutory lines like the health visiting service, but the ones, if you like, that are exercising our duty to take steps to improve the health and well-being of the population. The work we do in-house, the Quick Ready service that's a hero over there, manages the weight management service, all those things which are on the one hand discretionary, but if you like, they're the second line of things that the public health budget should be spent on because they are core services that help improve, they are the role and purpose of public health. Again, they are not provided by the NHS, they are funded by the public health grant delivered by the local authority. So whether we should do more to highlight our role in the whole health, is probably a valid point.
Okay, thank you very much. Mr. Harrison, and then Mr. Hills.
Thank you, Mr. Chairman. It's very impressive, all the numbers, but sat reading it and going through it carefully, I suddenly thought, well, blimey, I wonder how many staff you've got in this. So that was a question that jumped out at me, looking at it and thinking, well, there's still a lot of money here, there's a lot of things we're doing, but, how many staff do you have? Thank you, Mr. Chairman.
Okay, yeah, thank you for the question. So core departmental numbers are 72, 70, or it's a bit more at the moment, isn't it, because of some temporary funding?
It's about 118. Sorry, the full department is around 118. Some of those members of staff are paid for by specific grants and funding, but that's the total staffing for the department currently.
So that would include sort of departmental management team, the work of the consultants in public health and my DMT. That would include in-house services, wouldn't it? So I mentioned Quick Ready and the weight management service amongst them. But of course, the bulk of the staff is tied up in our commission services. So substance misuse treatment service, health visiting, missing a big one in there as well. What was it? Sexual health would be the other one. So I must admit, I have not got a clue the total number of staff in the entirety of the public health grant that we pay for, but essentially it's, I would say it's a relatively light and lean core function in in-house delivery with the vast majority of the money tied up in commission contracts from NHS providers in the third sector.
Thank you very much, Mr. Harrison.
Just like to say it's impressive, very impressive when you think of the grant figure and then the teams that are involved. It's very impressive. Well done. Thank you.
Dr. Hills.
Thank you, Chair. My question is more of a follow-up to Betty and yourself, Mike, in terms of what we pay for and what we don't pay for and what the NHS puts their sticker on. I'm curious, if you look at the obesity programme, it's only £10,000. And even if you add that onto the weight management service, that's 306,000. Obesity with diabetes and the knock-on effect is probably one of the biggest most harmful things that we have in the country. Do you think that's the right proportion of money to be spent on it when you compare it to things like sexual health, 4.2 million?
Yeah, that's a good question. You may recall when I brought my annual report here last, whenever it was, December, I did flag in there, if you look at those figures around the percentage of Leicestershire population that are meeting the 5-a-day requirements, it's not as good as I would expect for a population like Leicestershire's. So I think in there I did advocate, as we are within the department, doing a review of what we do around diet and obesity, because I think there's room to do better. The money is a difficult one. Again, we are the, well, I was going to say 8th out of 9, 9th out of 10 lowest funded authorities in East Midlands. Now Northamptonshire is split. Rutland is the lowest. So my budget's £27 million. Derbyshire's, for instance, it's a slightly bigger population, but not by much, is 45 million. So the point being, there are some core costs in delivering something like the health visiting service. So that £8.7 million for public health 0 to 19 is lower. I mean, we're still efficient, but if you like, every authority like Nottinghamshire and Derbyshire probably spends about 10 million quid on health visiting. Ditto sexual health, there's no other kind of fixed costs in terms of running that service, and the single statutory lines that just chew up a lot of the budget. The amount of, if you like, spare money to spend on public health outside of defined individual statutory lines is clearly going to be less for me, given 27 than it is for Derbyshire with 45, which is a long-winded way of saying, do we spend enough on obesity? Well, I think we do as well as we can. Inevitably, you tend to focus on the weight management service because that's your kind of point of contact with an individual. Do I wish we had more cash to spend on not generic, but the more general health improving campaigns, if you like, around obesity? Yes. That would need either two things, one of which is more money from the government in the public health grant for Leicestershire. I'm reminded they were going to move towards a fairer share back in 2015, but they never pursued that. Or we'd have to look at the kind of entirety of the budget and work out where do we get our bangs for buck from, and would we diminish one bit and put more into obesity? So I agree with you with caveats, which is the wriggle room's a bit short.
Thank you very much, Dr. Hills. I just purely on the basis of the figures you just quoted on Derbyshire versus Leicestershire. Given the population, we're about just about 90% of the population of Derbyshire. If we were funded on the same ratio as Derbyshire are, then we would actually have a budget £12 million higher. So, I mean, that's a huge gap. Mrs. Seddon.
Thank you very much. As you said, the wriggle room is quite short, but I think it's good to be able to manage the services through the added value of them, and probably when you're strapped for cash and the wriggle room is short, you're more likely to say, well, what added value will this give, instead of carte blanche where you can have anything you want, is questioning it and refocusing on those particular groups, and, as I say, adding the value to it. So yeah, well done.
Okay, thank you very much. Right, I'm going to move on to the next section, if that's okay. We're on to budget changes and adjustments and growth. Those paragraphs 11 to 14 on page 17, and also Appendix B on page 25. Are there any questions specifically on those paragraphs? Dr. Hills.
Thank you, Chair. It was just a general question on where we're at with the sexual health services update. Because I remember a report to the committee last year about how we're updating it in the county, but it says here that there's been a failure of procurement. So I was hoping I could get an update on that.
Yep, I can't recall where we're up to with the update. I think that covered the failed procurement, didn't it? Or did it? Remind me. That was, yeah, okay. So that, yeah, okay. So yeah, we are. I'll look to Adrian because I can't quite remember. We, I think we are very close to. I must admit, I'm not quite certain if we've signed on the dotted line an extension for 12 months with the current provider, which takes a bit of money because they're in a, they would say there's not enough money in the system. Again, I think we've been lean to the point of maybe being slightly malnourished in the amount of money we spend on sexual health. That gives us then 12 months to go out to market again learning on the feedback from the procurement exercise, where although we didn't get any providers come forward, they were a number of comments made by people who expressed, or providers that made expressed an interest at the soft market testing stage, then didn't flow through to a full bid in terms of why they didn't, which was something to do with risk share around online usage, also something to do again with the sum total of the budget that we went in. I've just looked to Adrian though, because I can't remember if we've actually signed on the dotted line. No, not yet. So we're still in negotiation. We'd like to get that. Obviously, we'd like to get that signed before March the 31st when the current contract runs out.
Thank you very much. Any other questions under those? Okay, Mr. Harrison.
On page 25, the graph is it's quite a big number there, thinking about your comments. Obviously, the saving of 300, I understand the background to that well. I think we all do on this committee. But there's other considerable numbers there, making that up to eventually 25, 26 is 890. So it's a big number, isn't it? So how can you explain what you're doing during the efficiency of how that goes forward?
Yep. You'll recall from what we've done. Thank you. Recall from what we've done over last year. The bulk of that has been in the projects that have come before scrutiny. So the homelessness one, £300,000. As you know, that was the contract that was previously held by the Falcon Centre. That's, don't want to say done and dusted, but you know that will land the £300,000 saving in 24-25. Physical activity and whole school food approach are at various stages of completion, but equally, I think we will land those. So 600,000 of the 890 is done from the point of view of doing the hard yards this year. So we start saving the money for the next financial year. And then in the other ones, Adrian, do you want to take on the general review and efficiency of internal commissioned and infrastructure stuff?
So the other one that is just going through its completed process is the review of the School Sustainable Food Award. So that's been out to consultation, and that is nearing its completion now. Internal infrastructure is specifically around redesigning some of our internal services to bring together some savings through that. And the review of commission services for 25-26, we are 67,500 towards that. There's a really small balance left for us to identify, but that will come over the next 3 to 4 months as we identify any additional savings that we can meet.
Thank you, Mr. Chairman. So you're pretty confident on the 890 as heading that's achievable? Excellent. Well done.
Yeah, definitely. I'd say the 24-25 stuff is, to my mind, it's done. It's all green. The latter years, slight bit of variation, as Adrian says, in terms of 67.5, but bearing in mind those particular transfer savings kick in 25-26, I'm sure we'll deliver it, provided the grant keeps pace at some stage with inflation, which I suppose is the unknown shot, because until that's, don't take it as gospel, because if they cut it by £2 million, then I've got a problem, but that's different.
Okay, thank you very much. Okay, let's move on to the third section, in that case, savings and savings under development. I think potentially we've just covered a bit of that because that also covers Appendix B on page 25, which I think Mr. Harrison has just highlighted, but it also covers paragraphs 15 to 24 on pages 18 to 19. So are there any other questions on those items? I think we're probably already covering off a lot of these actually on earlier questions, which is good. Okay, so we're going to move on to the final section in that case, which is external influences and other funding sources, which again, we've probably covered on some of the general questions, which are paragraphs 25 to 28 on pages 19 to 20. So are there any specific questions on those that we haven't already covered? I think we've probably covered all of those. No, I can't see any hands going up. So look, I think that is probably everything covered. I think in your opening remarks, Mike, you made it quite clear that the challenges that you and your team have been faced probably earlier than many other sections within the authority, and also you do have a sort of a unique position within this local authority, and I know you personally as Director of Public Health have a sort of a dual-hatted role directly to the Department of Health and also internally within the council, and that puts you in a very unique position by staff. You are in many respects probably under more pressure and more focus than probably a lot of people, given that dual-hatted role, and obviously the way that you've been able to tackle your funding over the last few years has meant that you're hopefully in a better place over the next few years as far as the MTFS challenges for the authority as a whole. I know Mrs. Richardson, I'm sure, will probably echo some of those points as well, but it's, that's testament, I think, to the level of questioning today, which is that most of the big issues I think you've already covered off in previous years. So hopefully, as you said, as long as budgets stay reasonably stable, you at least know where you and your team are heading over the next 3 or 4 years, which is good news. Mrs. Richardson, do you want to say anything before we come back to Mike?
Yeah, I just wanted to thank the councillors around the table for the comments made about, the work that is being done with the number of staff, etc., and the amount of transformation in the services and the reviews. So I do appreciate that, and I think the staff do work incredibly hard on this work. Thank you.
Thank you very much.
Thank you. And just to end on, yeah, you're right. I forget sometimes I'm a joint appointment of the Secretary of State for Health and the local authority. In my filing cabinet, I still have the joint letter of appointment signed by John and the Secretary of State, and the quiz question tonight is trying to work out how many Secretaries of State ago that was.
Hundreds, I suspect. Some of them in no doubt in post probably for only a couple of days. Okay, you need to look that up at some point. I think you can't get away with not looking that up. Maybe we'll have a whole paper on that. Okay, Google. Okay, there we go. The answer to everything. Well, look, thank you very much. Thank you very much also to your team members. I know, as ever, these things are joint efforts, so greatly appreciated. And thank you very much, Adrian, for joining us for this session. If you want to escape, by all means, please do. So we'll now move on to item 9, which is our paper on vaping and young people. Welcome to Gary and also Zahira as well. So welcome to both of you to join us. I know this is obviously a paper that this committee asked you to come forward. It's something that's been, I think, a long talked about issue from committee members who have raised ongoing concerns, reflected by those from residents as well. So thank you very much for bringing this paper to us. If you want to say a few points on it before we then launch into any discussion.
No, I'm quite content to hand straight over to probably what Zahira first and then Gary. All right.
Zahira.
Thank you. Good afternoon, everyone. I suppose, this paper is to inform Scrutiny about the work that Quit Ready Stop Smoking Service is doing around vaping and young people, and also how the additional government smoke-free generation funding is going to help support that work going forward as well. So we know that we're going to be getting an estimated £716,000 into public health through the smoke-free generation money. And this is part of the government's plan to reduce smoking prevalence and work towards a smoke-free generation by 2030. We will have, I suppose, more confirmed details by the end of this month. So just a little bit of background in terms of e-cigs, vapes. We've all heard of them. It's a battery-powered device. It contains nicotine, flavorings, and other additives. We know that there's been an increase in vaping prevalence nationally as well as locally. What I did last year in November, we looked at conducting a survey because we had some national information on vaping, but I wanted to know what the local picture looks like, which drove that survey. And we had over 1,100 respondents. Quite a few things came out of that to help inform progress and how we move forward with it. There were 25% of children using vapes, and a majority of them were using it for 6 months or more. Currently, I think we are in a bit of between a rock and a hard place. There's no national steer or guidance as to how stop smoking services need to support young people who are vaping. But we've taken a proactive approach, I think, firstly by doing the survey, but then also working with partners, etc., to try and increase education, raise awareness of vaping with young people. So we know it's an effective stop smoking aid for adults, but we also know that children should not be vaping. And what we need to be looking at is reduce the number of young people having access to these products, and especially the non-compliant products. And we have been working with Leicestershire Trading Standards as well, in terms of trying to tackle this agenda together, I guess. I believe in the last quarter, there were around 84 complaints received through Trading Standards. 63 were relating to children under the age of 18 using vapes. So in terms of our proposals, our work, what we're doing, how we're moving forward with this, the councils, the Quit Ready Stop Smoking Service are working with schools. We've produced a toolkit for secondary schools, a lesson plan for teachers, to provide them with, I guess, support pack, information around the problem, information around vaping and how they can support young people going forward, also together with the laws and guidance around vaping as well. This was also distributed via the Teen Health Service. And what we're looking to do going forward is use that smoke-free generation funding money to recruit young people tobacco specialists who can work with young people. So it's dedicated support and work with schools to provide them with, help them shape, I guess, their policies and procedures around vaping within schools as well. We also looking to engage with young people in them producing some posters and information and resources, because I think to get that message across, it's best to get their views and for them to, I guess, promote it within amongst their peers. And we'll incentivize that approach by providing, I suppose, a winning school or young person, whatever, with vouchers, and that will contribute towards the school. We, as I said, work with Trading Standards, and we are also linked in with the Regional Tobacco Control Network, so other local authorities, stop smoking services, etc., working together with, around vaping and looking at that. We've just been awarded the National Swap to Stop scheme, which is, in a nutshell, encouraging 1 million smokers to swap over to vape, but this is adult smoking, or smokers swapping over to vapes. So in terms of the service expansion, as I mentioned previously, the young person tobacco specialist will work with schools. We will be looking at concentrating on smoking cessation, but I think also providing, the advice around, vaping and not using vapes and that kind of thing. So first line of treatment for young people is the licensed nicotine replacement therapy products. So we'll be looking at that. And then, as I said, working with schools as well. To tackle this issue, I've always said we need collective support and buy-in from partners, our organisations, which obviously include schools, youth councils, children themselves, parents, Trading Standards, etc. And yes, I suppose just in conclusion, as a public health department, we do stand by the stance: if you don't smoke, do not vape. And we know that vaping is not risk-free, but we do know that it is a safer alternative to smoking. However, children should not be using it. And the smoke-free generation funding stream will also help strengthen our smoking cessation offer for children, reducing smoking prevalence as well as vaping prevalence, and hopefully work towards the creation of a smoke-free generation by 2030, which is the government's ambition. Thank you.
Thank you very much, Gary. Are there any couple of points you want to add?
Yeah, I can only address this committee from an enforcement perspective, really, from a Trading Standards point of view. We, in Leicestershire, we seized around, in 2022, about 33,000 vape products. a large quantity of those were from via East Midlands Airport, which I'll cover in a minute in terms of latest news on the funding, on the national funding. The significant problem for trading standards is and legitimate businesses is non-compliant vapes, essentially. So these are vapes that are either there's no provenance to them. We don't have the resources to test analysis on quantities that we do seize from the high street, essentially. But the fundamental problem with those is either the content of nicotine or the whole content of the vape and what other chemicals are within it. Clearly, it's an illicit marketplace and it is linked to other illicit products and, shall we say, organised crime, money laundering, etc. So we do have interactions with other enforcement agencies on that. There is an operation called Operation Joseph, where there's some money coming from the Smoke-Free Generation funding that's reaching Leicestershire. And that's all about really seizures in the marketplace. One of the big problems we have actually in terms of cost is disposable vapes and the cost of getting rid of them. So, for example, here in County Hall, we've got to have a specialist storage facility to store them, and it's costing thousands to get rid of them, which is a problem then for Leicestershire. We do take prosecution cases for non-compliance in relation to the regulations, and many of the cases result in, shall we say, somebody else fronting the business. They are expensive cases to prosecute from that perspective. Hot off the press is, as of Friday, we were notified by Department of Health that we are to receive £75,000 funding for work at East Midlands Airport. So we currently have a product safety team dealing with general product safety, where we seize and detain unsafe products at the port of entry. But they've released some of this money under the Smoke-Free Generation funding to allow Leicestershire to expand that team. It's only over a 15-month period, but our current intelligence tells us that there are large quantities coming through East Midlands Airport in terms of the illicit products. Some of those, of course, will enter Leicestershire. We are part of the National Ports and Borders project from that point of view, so it benefits the country as a whole. Hand on heart, trading standards enforce a plethora of legislation, and we have significant resource challenges in terms of enforcement. I'd say we're well beyond the tip of the iceberg, but we cannot action every allegation that either comes via a school, by a legitimate business. We have not got the resources to undertake covert test purchasing exercises with children. We did that in the past, but we don't have the resources to do that now. So we have to be quite focused, intelligence-led, and deal with the most fundamental problems. But it's out there on the high street, and it is. We are the more funding we receive, the more we'll action it. Clearly, we're no different than any other county in terms of what we think the degree of criminality is in relation to the supply of these illicit products. So we're no different in that sense. We do get quite a lot of intel from schools as well, and worried parents. For example, vaping products are known to be used to shroud children taking cannabis, for example. So there's wider health issues away from our function, but I'm just trying to give you an overview of how we're trying to tackle it, recognising that this is a national issue. The way they're going on enforcement is to try and fast track that, and the consultation is about fixed penalties and trying to deal with them through the court system quicker, while outside of the court system. Whether or not that will resolve the issue, who knows? I'll finish there.
Okay, thank you very much to all of you. I'll just open up with a few sort of comments, really. Reading the paper was very informative. I have to say, listening to the two of you sort of going a little bit further than probably what was actually in the report. Enlightening, but also slightly horrifying, because clearly there are a huge number of contradictions and issues covered by your comments. The fact that clearly vaping and smoking is, completely intertwined as far as one is seen as being an alternative and a less harmful version of the other. But of course, a lot of what we're talking about is actually the whole issue about smoke-free generation is actually about, trying to get a large section of our society away from smoking full stop. Now, by default, that also should include vaping, because to be frank, vaping is not an alternative to nothing. I mean, it's an alternative to smoking as far as public health messaging is concerned. And at the moment, we have vaping that is, permissible as long as you're giving away the objects to children. If you sell them, it's illegal, but you can give them away. So, where is the incentive to not actually go down the routes that are clearly open to abuse? And we're using a huge amount of funding that is actually aimed specifically at reducing smoking, but actually on tackling vaping in an age group that is not even looking at smoking as being an option. They're actually going straight to vaping, and it's 20% of children trying vaping is just horrific. If that was smoking, we would have serious problems. But the fact that it's actually vaping and the system is not being applied evenly by legislation is horrific. And I absolutely my all sympathies to you, because your hands are being slightly tied behind your back on as far as the sort of unequal way that legislation is being applied to vaping and smoking, when quite clearly in public health terms they are one and the same thing as far as an issue that we're trying to tackle. Again, the point about seizures, you made a very, very valid point, which I think a lot of people have referenced without through sort of hearsay, but clearly is a very, very valid reason, which is we just don't know what's in a lot of these things, and the risks in public health terms, but also in long-term damage to not only the adults that are using them, but particularly the children that are using them, is just horrific to imagine, and will maybe be years until we actually discover the impact that they will have on whole tranches of our demographics. And not being able to actually take a much harder line with it, I think is very frustrating. And I suspect that you probably are being pulled in many directions, because again, the tools that you have available, both through money but also through personnel, means that you can't actually tackle the process that you're actually facing in a way that you probably want to do so. So I'm sure we're going to get questions. I know we've got a question from Mr. Harrison, also one from Mrs. Newton. At the end of this, I think my personal feeling, and I'll listen to the comments from the room, but I from a committee, given past comments, I suspect that probably we'll be looking to try and actually contact the MPs within our area to ask them to actually include vaping within the current smoke-free generation proposals, to try and actually outlaw vaping to the children, and as generations get older, to all of those generations as well, because unless we actually treat the two as the same, it seems that it's an absolute nonsense. But anyway, I'll take some questions. Mr. Harrison first, and then Mrs. Newton.
Thank you, Mr. Chairman. Could I say congratulations, wonderful report. It does open lots of doors, which has been mentioned, and it certainly opened my eyes. When I heard of vaping, it was quite an innovation to help you give up smoking, and I thought, okay. But now once you start to undo the lid properly and see what's in there and the implications, it is absolutely frightening to think that they can stand around and hand this stuff out freely to young children, and no offence, but obviously what's ever in that vape, if it's a sort of nicotine or some addictive type of drug that's used, or because Gary's comments were very open and honest. I mean, they've not got the laboratories to be able to pick stuff up, challenge it. They haven't got the resource, and above all, they haven't got the money to be able to say, right, the more we take to court, the more we successfully prosecute, the more we're going to dent this thing good and proper. So it's got to have a huge sort of attitude to all of this, because we are confronted with a really, really serious problem. I spot young children, quite, I say young, they're 13 or 14 maybe, coming out of school. Maybe the time I get back, I might have seen some of them again driving along, and they're there, and we've got the vapes. They're actually vaping, walking along the street, and there's obviously hundreds of these children leaving school all at one time. So there's a lot of stuff going on, and I think it really does need a really massive strategic think about and discussion to find what is the golden arrow. How can we actually get rid of this? What are we going to do? And maybe it won't be just one. I'd love to think it was only one, but there's probably going to have to be 2 or 3 different target approaches to say, how are we going to deal with this? How are we going to stop it? How are we going to influence young people and let them know how serious and dangerous this is for them? It's an addiction. That's all it is. It's an addiction. And whatever they become addicted to, then they're going to want, aren't they? So it is very, very good. It is worrying and concerning, because the chair actually said you've opened the doors, and you know there's lots and lots of questions. We haven't got all the answers, unfortunately, but it will need a very big concerted think about how to do it constructively. And you know, we don't have the power of legislation, so we've got to think how we can maneuver ourselves to influence young people on the dangers of this. So that will be a key target, and obviously I really wish you well and hope that you're very successful with it. Thank you, Mr. Chairman.
Thank you, Mr. Harrison. Should we take Betty's question as well, and then I'll give you an option to come back?
It's not so much a question, but it's a comment. I do a lot of work. I stand outside schools and places like that and chat to parents. And I think what's out there is parents see it as an alternative to smoking. They don't see it as a problem within itself. And I just wonder what more we can do in terms of adding to that agenda and saying, it's one leads to another, but one is as dangerous as the other. It was more or less, what more can we do to inform people that vaping is a problem in itself? Thank you, Chair.
Thank you very much. Actually, we've got Mr. Charlesworth as well, and then Dr. Hill. So should we take all the questions and Mr. Bannister? Mr. Seaton, you may have to think of a question as well, and then we've got everyone. Okay. Mr. Charlesworth, you go first.
Thank you, Chair. Yeah, I think the direction has got to come from above. I think the government really needs to pull its finger out on this and give us some help, legislative-wise and direction. Otherwise, we're floundering a bit. There's a lot we don't know about vaping. I mean, I don't even know what the cost of a vape is. I think a packet of fags now is what, 15, 16 pounds? I wouldn't know how much a vape is. I really wouldn't. We don't know the long-term effects. We don't know the real effects on the brain, the body. And until we get definitive stuff like we did with smoking, then we can put these horrendous pictures on cigarette packets, which I think works. They're not particularly pleasant, but they're there for a reason. And that sort of campaign has worked. And now smoking has become pretty much socially unacceptable. It's worked. The confusing message for young people is, if you're an adult smoker, it's better to vape. Therefore, the young people think, well, if it's okay for adults to vape, the message being it's okay to vape, they probably don't see the connection between stopping smoking and vaping. They just think, great. And of course, there's millions of flavours, apparently. It's like alcohol. Youngsters wouldn't have gone into a pub and bought, if they could, gone and bought a G&T. But they'll buy a G&T now because it's flavoured. And the marketing people at these firms have to answer as well They're the ones driving this. It's the advertising and the driving that's doing it. And why do young people take up vaping? Is it peer pressure? Something to do? Cool? Does the nicotine actually work for them? Or are they just doing it because their friends are doing it? I think there's a lot we don't know that we need to understand. I think it's appalling that trading standards have had the covert facility taken away. That was very useful. Funding should be found from somewhere to bring that back, because you need it on the headlines that so-and-so shop or whatever has been doing this. And you need to name and shame and stop people that way. There's limited work I think the schools can do. You know, you can do what you can, but it's a tide that's going against you. Young people will find these products as they find other products quite easily, baffling to some of us adults how they get hold of some of these things, but they do and they will. I think you've got a hell of a job, but legislation needs to come from above. It's like e-scooters. Apparently 250,000 was sold at Christmas, but you can't use them on the roads, but everybody does. But the legislation still isn't there to get rid of it. So it's got to come from up there. Thank you, Chair.
Thank you, Mr. Charlesworth. Right, I'm going to take all questions in one go, and then we'll come back for any answers or points. So can you remind me whose hand went up first between Mr. Bannister and Dr. Hills? We'll say Mr. Bannister, go on then, and then we'll get Dr. Hills, and then finally the best question of all come from Mrs. Eden.
Thank you, Chairman, and thank you for the report. A very interesting read, and I was struck by the numbers in paragraph 4 about the exponential growth of young children using vaping. And I do wonder how many of them actually do know that there is the nicotine in the product, and that nicotine is addictive, and that there are effects on their still forming brain that affects a number of functions. And that sort of education process hasn't yet filtered through. So I urge every effort to be made on that education front. But of course, with 20% of children using vapes, and Mr. Harrison referring to children coming out of school vaping away, somebody is selling these vapes to them, and that begs the question about enforcement. And hats off to trading standards. I know that life is difficult because of the resource challenges that you have, but that really is a key, and we need to inform the powers that be that hold the purse strings that one of the major weapons in this battle is going to be over proper enforcement. So I hope we take that on board. I note what the chairman said about the smoke-free generation and the smoking bill that's currently going through at the moment. Has Public Health done any lobbying or having had any discussions with ministers during that process about including vaping with regard to the smoke-free generation as well, to try and add that into the legislation? And I'm sure that individual members will do their own lobbying to their own MPs, but I'm just wondering if there has been any discussion at ministerial level at this stage. And the other matter I just wanted to raise was something that I was picking up just as I was doing a bit of background reading when I came across heated tobacco products. And it did remind me that I did pass a shop which had the sign heated tobacco in its window. And when I saw it, I didn't realize what that was. But reading around the subject last night and learning about heated tobacco products, or HTPs, this is tobacco in a heated format so that it can go into an aerosol. So it's similar to a vape. And I was just wondering whether or not that's also on the horizon, whether or not that is also going to be something that may interest children, and what the industry is doing about, HTPs, and whether or not this is going to be the next big thing But it's again something that public health really need to be aware of and to appreciate whether that is also going to be, as I say, the next big thing that needs to be tackled. But I'll leave it there. Thank you, Chairman.
Thank you very much. We'll wrap up all the points at the end if that's okay. But absolutely, we'll pick up Mr. Bannister's points as well. Dr. Hills.
You got me. I'll start again. I'd like to thank you for the report and echo what other members have said about it. It's very, very informative. And I sympathise, again, as other members have said, because it's going to take national legislation to tackle the root of the problem, most likely. And it's a very difficult thing to do because at the end of the day, you know, kids find vaping cool. And that's why they do it, you know, and I think as cigarettes are becoming less and less cool, vaping seems to be the one taking over. I think well done as well, it says about the teaching packs that have been sent to school and the lesson plans that you've done. I remember when I was in high school, I had to bring in an Argos catalogue, and the teacher said to me, you know, it costs £500 a year to smoke. Why don't you cut out £500 worth of products, stick it on a poster, and if you don't smoke, you can buy those products instead. And I still remember that, you know, 15, 20 years on. So obviously it does work. So well done on getting ahead of the curve. I've got one question for you, Zahira, and one question for yourself, Gary. I think it was, you know, a very good idea to do the local survey. 1,100 responses, I think you said, is a very good number of people to respond to that. I was surprised, though, that it says in the report that actually a lot of people that are vaping right now were already smokers in the past. Is that correct? Because I'd be very surprised if that was the case. From talking to family members, and I've got a 13-year-old niece at Heath Lane Academy in El Shelton, none of her friends smoke, you know, but a lot of her friends do vape. So can you just confirm that that's correct, that that's what the survey found, that actually a lot of the kids that are vaping right now are also smokers at the same time?
Yes, so I believe the survey that we did, there were a lot of children already smoking or have been smokers before going on to vapes. So that's what that, but I take on board your point because I also have teenagers in college and a lot of their peers, you know, are vaping and not necessarily have smoke. So anecdotal evidence suggests otherwise as well. But I think, you know, we've got to tackle it. I'm not looking at it as young people who have been smokers and moving on to it. It's young people vaping. Bottom line, young people shouldn't be vaping. So that's how we're looking at it going forward.
No, perfect, and completely agree. You know, rather than trying to confuse us with the message of people stopping smoking in younger ages. My next question was for yourself, Gary, and it's more of a scenario. Say I'm a parent and I've got a young child, they're 13, 14, and I found a vape in their bag when they come home from school, and they said, oh, I got it from the co-op down the road. What do you want the parent to do? Because you said that there's no resource for covert test purchasing, which is by what I mean, I presume you mean where young people go to the shops and you test them out, and if they sell, they get in trouble. What would you want the parent to do in that scenario?
Okay, so prior to the resource challenges, we would have taken that piece of intelligence. They would report it through to trading standards or possibly through the school or even through public health or whatever avenue they use, the local police. We would then gather that intelligence, and we'd set up probably 4 or 5 times a year a test purchasing exercise using under 18s children to assist us, and we'd be more proactive in that. What we have to do now is essentially bang on the door, go and see the retailer. Clearly, if there are illicit products, not products that are tobacco products but are compliant with UK legislation, then that's an issue about an age-restricted sale rather than the product itself. If it's both, so it's a sale to an under 18 but it's an unregulated illicit product, then we'd bring that to the attention of the trader, and we'd look at our enforcement policy to determine, A, have we got the evidence to prosecute, or is it appropriate to do so? I would suggest in that scenario, it's kind of a shot across the bows, a warning letter, and then we would possibly monitor that business as best we can. What we currently do with illicit tobacco products is that we still carry out some covert activity thanks to some funding from public health, which is around 60,000 a year for illicit tobacco, where we will use a test purchase and excise, but that's using an adult. That's not an age restricted issue. That's about illicit tobacco products. And we then subsequently execute a warrant and seize the product. And those cases are ongoing all the time. So the nature of that premises is more likely, especially if they're stocking illicit products, to be supplying to underage as well. The other issue, of course, is that Facebook Marketplace, online sales can take place on a regular basis. We do some monitoring of Facebook if we get a piece of intelligence that lays us to Leicestershire as such. So we have to be proportionate in terms of how we respond, in terms of the seriousness of it. If it was a school that came to us that said, this particular retail establishment is hammering it out to all our pupils, then we'd probably be we'd find the funding to be more proactive in that situation. But we would simply be out with all our staff because of if you combine that with, we're talking about vapes, but tobacco products generally, illicit tobacco products, it's a massive problem. And it could take up all the resources of our Trading Standards Service just to get on top of it. When we answer the rest of those questions, I'll talk a little bit about the consultation from an enforcement point of view and what that's covering and how we responded to it. Hope that answers your question.
Okay, thanks a lot. If you want to come back on anything.
No, I was just going to say, I'm glad to hear that you're still visiting, even if you're not doing covert test purchasing, at least something is being done there.
Do you want to come with anything now, or do you want to actually hear the answers and then come back? Excellent response. Okay, look, you've heard a number of points, some of which were specific questions. You had a go at Dr. Hills's specific questions as well, but if you could come back on some of the points that you've actually heard us talking. I know we are, as a committee, I have to say, it's the one issue that I think we are as passionate about as anything, because I think it's been growing over a long period of time. And I think this is the moment that we actually have a go at trying to make a response to it. So over to you three.
Okay, yeah, if I lead off, and then I'm sure Gary as a hero will chip in. So, pardon me. First off, to address Dr. Hills, I was thinking there are always certain events or signifiers that when you get later on in life give away how old you are. So for some of us, it'll be like the World Cup win, it'll be man landing on the moon. For me, it's the ZX81 home computer. I didn't realise hard copy Argos catalogues was going to feature in that one. I'll leave that one with you. Wait till you're old. I remember there was hard copy Argos. Really? You're old. Anyway, so in terms of regulation, there's a few things to cover. Just in terms of regulation, I did have a look earlier on, thanks to Zahir and Gary for looking this up, reminding me. So the smoke-free generation consultation does include questions around vaping, notably around the kind of more child-centered stuff. So the colours, the advertising, the bits and bobs, the flavours, the stuff that is more obviously kind of centered on young people. I'm pretty certain there's been various consultation responses that we put in either as a county council or as a collective association of directors of public health, for instance, and I'm sure Trading Standards professional body did the same. I think in terms of a conversation with MP, there's a couple of things that spring to mind. I'm not certain that recognised, picking up your point, Chair, about the sort of putting the two together, tobacco and cigarettes and vaping. I'm reminded that my local supermarket, they used to have in the newsagent stand kind of stuff of the supermarket, the displays of cigarettes that you'd have seen everywhere. And then along came the smoking regulation, which meant you had to put those behind doors. Recently, they've gone and put the tobacco and, the roll-ups and stuff under the counter, and they've made that bit a vape bar. So you're back to having the attraction of lights and going up and not feeling like you're asking for something under the counter because you've got nice bright lights. It's a nice thing to do. So there is something to maybe pick up around going a bit further, recognizing that kind of behavioral link or the kind of advertising link, if you like, between the two. And then the other bit, and again, that's looked as a hero to come in due course, is, again, this, you could take the view that vapes only be available as a medicinal product. So you would prescribe them to a smoker as a cessation aid, but you wouldn't allow them on general sale. And that's clearly something that isn't currently within the scope of the consultation. So there is that sense of how far does the current consultation questions go? Do they pick up everything that the committee is concerned about? There is the obvious point for me around enforcement, which gives me a chance to sort of big up Gary. So coming back to the public health grant, as I said, it's to be spent on public health functions, but there is an awful lot of things, trading standards enforcement activity, that isn't a public health function itself. It's a function of something else. It's the function of enforcement to enforce the law. The fact it has a really good impact on the health of the population is a great secondary objective. And I think maybe we talk in the NTFS a lot about the big cost drivers and the budget pressures on the council, which is, you know, obviously social care, and I kind of get that. But actually, it's almost like there are things that maybe have been cut a bit more, like trading standards, where actually the impact of that isn't just on regulation, it has a big impact on the health of the population as well. You know, and again, I'm sure you'd agree with that, Gary, as we go along. What was the other bit? In terms of health concerns, again, I think it's an interesting one, and I suppose really part of me, as I think we said in the paper, was at the moment, would I say that vaping is as dangerous as smoking? Well, no, it's not. As I've said before, when you've got tens and tens of years of evidence that smoking will kill a half and more of smokers due to a smoke-related illness, versus a small but growing number of people who've suffered acute inflammation of the lungs from vaping, then the balance is there. But I think the thing with the committee, as I said with all show, is like, it's not often you get a chance to get in early with a potential threat and try and nip it in the bud before it gets worse. So there is that element of taking action now. So we could say, is it as harmful as smoking? No. But then again, the answer is we don't know either. And combining the two, I was just looking at it because I was trying to remember, going back to the history bit, in the mid-80s, you might remember there's a lot of push for a couple of years, around about 86 as a year I can remember, around snus, you know, the sort of tobacco products you put in your mouth. Skull Bandits was one of those things that just seemed to be advertising everything for a couple of years. And in the end, I think it was part of EU law, but we've adopted it as well. You know, we've ended up in the UK a position where snus with tobacco and nicotine is outlawed for sale. You can use it legally if you're over 18. So the point about Amazon-based purchases still stands. But, you know, that was an early piece of action back in the 80s to basically look at a new product, because there will be forever new products coming through, and go, no, we're going to stop this before it goes any further. So there's a sort of a mixture of things in there. But I think in terms of consultation, we could probably have a conversation which picked up pushing the government piece further, making certain that actually enforcement and the proper resources for enforcement is fairly critical. And then above all else, a desire not to come back in 10 years' time and find that we could have taken action, but we didn't. So I think there are a relative number of things from that. I don't know if others want to add to that.
Just on the consultation, the consultation is actually now closed. Rishi Sunak was very keen to get it out there, and it covers, I can respond in terms of an enforcement or public health perspective, but they are looking at things like restricting the vape flavours to make them less attractive for the children, if you like. Regulating point of sale is one. So is it appropriate to license? At the minute, you don't need a license to sell a tobacco product, but they're looking at that, which from an enforcement point of view may be a little bit easier because it becomes a licensing issue. Remove the license if they deal with illicit products. In terms of enforcement, how they tackle the types of offences involved, I think there's even a discussion around duty payable, which would have certainly with vapes will impact in terms of how that's controlled by UK border forces as it enters the UK. So that there's regulating the point of sale itself in terms of what's available, similar to what Mike's saying. So that there's quite a plethora there of discussion points. I do know that from a trading standards perspective, we responded on 3 levels. We responded as Trading Standards East Midlands through National Trading Standards, and also the Association of Chief Trading Standards Officers. So we've been fairly proactive, and I know that we were approached by 2 or 3 MPs as soon as this consultation came out. I can't recall which ones, and we've been in touch with those and said, yes, we be assured we've responded. I think most of the responses from a regulator's perspective have all been very similar. I would suggest, I don't think the first part really of this first lot of funding from an enforcement point of view is to actually identify the scale of the problem in terms of the illicit market and how that impacts on the health issue, primarily around age restricted, how that impacts on children. So we're relatively satisfied. I think we've been fairly proactive as a Leicestershire County Council. I know Mike's side have also contributed from a public health point of view. So I think we've done what we can. It is an issue of resources, and I think that is where the crossover arrives with public health. But hopefully the outcome of the consultation will get listened to. But what really counts is the funding that will then follow. This funding we're getting at the minute is interim to identify the scale of the problem, but it will need a commitment.
Just a little bit from me, really. I mean, echo everything that you guys have said, and just in terms of, you know, the problem at hand for us as a service, for me as a manager of that service, it's a moving beast. We're learning as we going along, but as I've said, it's you know, it's going to take collective support from, you know, schools, from ourselves, our partners, young people themselves, to make a difference. And we're going to need, obviously, legislation. We're going to need that national steer to help guide us as Stop Smoking Services. But rest assured that we're doing, you know, a lot, and a lot more than I would say other Stop Smoking Services nationally. We've been really proactive in our approach, and in fact being asked to share, you know, the work that we're doing in Leicestershire with other Stop Smoking Services, so that they can take some of these ideas and approaches forward as well. And yeah, I mean, all the things that I've identified in the proposals and what we want to do, hopefully, you know, with schools will have some impact. So fingers crossed. So
Brilliant. Thank you very much for that, and thank you very much for the responses. I mean, it's good to know that we've responded to the consultation itself. I think obviously once we actually know what the legislation looks like and what it's being provided, there are options then obviously to have it amended either through the House of Commons or through the House of Lords, and it may well be that that's a good opportunity to actually then put some pressure on if we feel that there are particular improvements that could be made that are beneficial to the way that we can then respond to the problems. I think as a basic point of principle, I think, you know, personally, I would always want to see tobacco and vapes treated as one when it comes to age groups. So, you know, the idea that you can give away vapes to children, but obviously you would not be able to do the same with tobacco, seems like an absolute nonsense. And whether that's actually something that the consultation responses have been focusing on, I don't know, because, you know, if the consultation responses are actually about flavours, that slightly makes me nervous that they're actually not fundamental, as in actually no flavour should ever be presented to a child as being an acceptable form of vape. Licensing to premises, I can see the absolute attraction to that, because that would also help to take out things like Amazon and also Facebook selling probably a lot more easily. But certainly, you know, as soon as do we actually have a view yet as to when the legislation is likely to be published?
No, I think it's far too early days. I think it's kind of this intelligence gathering at the minute, fact finding, run the consultation, and then determine things from there, really. So I don't think there's an actual timeline I'm aware of, mine.
I'm not. I'm tempted to say I would find it hard to believe that parliamentary time would be freed up this side of an election. So again, there is a cross-party view. I think we probably have to take on this, you know, just in case, or depending on the result of the next election.
Okay. Well, look, let's take a look at that. I'm tempted to, because I know we have obviously a number of MPs that have raised this as an issue former health ministers in particular, who are very keen to actually see vaping pushed through in the same way that tobacco is. So I am tempted, if the committee is happy, for me to actually write to our MPs just to actually demonstrate our strength of feeling on this as an issue, and to encourage them, if possible, to find time in their diaries to raise it or to talk to us about some of these issues. If you're happy with that. Okay, good, thank you. Now, Mrs. Eaton, is there a final question you would like to ask at all?
I don't really want to say that. I'm recorded. I started smoking when I was 13. And so my memory isn't Argos catalogues, it's illicit radio stations on the high seas that my memory goes back to about those times. We shouldn't be having this conversation. We really shouldn't. It should have been headed off a long time ago. When there was other illicit products being sold on there, and as soon as we stop one, something else takes over. So we want legislation that covers all of those aspects, and I'm hoping, amongst all hopes, that the smoking cessation purposes only, and not towards tobacco enforcement, for the support that you give. You're not giving away vapes, or are you? Is that smoking cessation programme giving away vapes? That was my question. Thank you.
We do give out vapes. We do provide e-cigarettes as part of service delivery.
And is that monitored, or is it done willy-nilly?
Go on.
No,
It's monitored. It's provided to obviously any adult over the age of 18. There's a disclaimer. They've got to send in identification to prove that they're over 18. And we provide it as part of the 12-week treatment behavioural approach, because that is what the national guidelines are for smoking cessation. It can be provided alongside conventional pharmacotherapy. So that's what we provide to our clients, should they want to. But it's an informed decision as well. They provided with the full range of information around the licensed medication as well as e-cigs, and it's then up to them to make that decision in terms of what type of pharmacotherapy they want to use.
But just to reinforce, we don't give them away willy-nilly. I mean, if you come to the smoking cessation service, you get your behavioural support and all your patches and or an e-cigarette, etc., because again, comes down to, if you're a smoker, vaping is better than smoking. Whether that then corrupts the message about treating them the same, I suppose, is a good point, but that's part of the consultation and regulation.
Thank you. I need to follow up my last statement. I don't smoke now. I stopped many years ago, and I'm glad you don't give them away willy-nilly. I've been told that there are places that do so, that will, a vape will advertise at a carnival or a fete or something like that, and be able to give them away. So obviously the legislation will stop that sort of thing from happening when the legislation comes in. But it's a good report, and as I say, it's something that we shouldn't be talking about. It should have been stopped a long while ago. And yes, like I put down that licensed premises, vaping shops, and cost, of course. That's the thing that stopped me from smoking, was the cost. So there you go.
Thank you very much. And to reinforce actually Mrs. Eaton's point, I remember not long ago actually walking through the middle of Loughborough, and there was a huge truck advertising vaping parked up in the middle of Loughborough, promoting vaping, and I'm assuming probably giving away vaping units at the same time. I have no idea, how they control that. If they're just handing out products. I mean, I'm assuming there's no ID being shown to demonstrate that the people are underage, and I don't know whether we actually have any role at all. I suspect absolutely none as to how these organisations go out and give away their products, which is slightly horrific, really, given everything we know, and even more so. Okay, well, look, thank you very much. Really good session. We will no doubt come back to this as and when we have more information. Thank you very much. Thank you very much, Sahira. Thank you very much, Gary. And thank you very much, Mike. So we're now on to item 10, which is the Leader Annual Report. I think we have, here we go, coming to the desk. We've got David, who's a Group Director, Strategy and Partnerships. We also have Mandy, who is our Lead Practitioner, Adults and Communities Department here at County Hall. And I think that's it, isn't it? There we go. Right. Okay. Well, look, thank you very, very much for listening to the last item. And great report, which I had the opportunity, likewise the slide deck, which we looked through, which was absolutely brilliant. So we'll take all of that as read, because there's some great material in there, which I know we'll want to ask questions on. But by all means, if there are sort of a couple of minutes that you want to spend setting out particular issues that you feel are important, or you wish to draw our attention to in the reports, then please do, and then we'll come back to questions and debate. Thank you.
Lovely, thank you, Chair. And I just thought I'd start, first of all, just reinforcing the fact that coming today to talk about the lives and deaths of people who've had learning disability and autism is, hopefully Mandy and I are demonstrating today, it's a joint approach between local authorities and the NHS and ways of working. So Heather Pick, one of your assistant directors, is the joint SRO with me across the whole of LLR, supporting stuff through, and we've taken that joint approach in the way that we're working things through. A couple of bits I just wanted to draw out, and literally just over a couple of minutes, and a key way of doing. Really important that we look at the lives and the deaths of people who've had a learning disability and autism in LLR in order to learn what we can do differently. And we do an annual report of looking at this and then thinking about what's the key themes and what's it showing us. So what we know from 22-23 is that we do know that we've had 83 people die with a learning disability and autism. 82% of them were white, and the average age of death was 62. So that's something like 20 years earlier than the average age of death for the population across LLR. So a significant difference in way of working through. I think I wanted to reflect also that we're really aware about the inequalities and about the fact that 82% white. And there's two things there. One of which is we're very aware of the inequalities and are having a look at the work and understanding and where things are going and how do we make sure people get access. But also the other thing I wanted to flag is that Leader is looking at the average age of death. Now we know we've had historic inequity in diagnosis and ways of working things through. So seeing a change in Leader will be a lot later than a change in diagnosis rates for people and individuals. So there's going to be that inherent time lag of correcting behaviours. But I think we all recognise that's not an excuse. We recognise the data and we're doing something about it. I thought I'd just flag that of the people who have died from aspirational pneumonia, 34% of those deaths are avoidable. And I thought aspiration pneumonia is worth just talking about because it's a kind of key theme of some of the things we'll talk through today. Aspiration pneumonia is essentially things being in your lungs that's not air. So that's quite often things like feeding, food going down the wrong way, liquid going down the wrong way. And actually that all comes down to the basics of good care. That's families, parents, carers, care homes, the NHS, community providers, all providing really good care. And some of those deaths are, 34% of those deaths are avoidable. So it kind of takes me into a theme of if we do the basics right and we do the basics well, wherever we're doing them, then we deliver really good care and people will live for longer. So I think I wanted to do that. Another example for you is we highlighted in there about venipuncture, so blood taking. And if you think about the position you might be in, that if you need a diagnostic test, particularly within the NHS, one of the first things that will happen is we'll take bloods, analyse those bloods to identify what help you need. If you are unable to consent to having blood taken because you've feel it's an invasive procedure, you really don't understand the purpose, the reason, and why going by it. It's incredibly difficult for anybody to diagnose what's wrong with you. So again, enabling people to be able to access the basics, right? To be able to have the right support, for us to think, how do we create blood taking services that meet the needs of everybody, is all about getting the basics right, all about providing the right support and a way of going. So in the rest of the report, we've got a top 10, we've got kind of key things to think about. But I think if I was to leave you with a couple of quick bits, in general, the more we all talk about really good care for people with a learning disability and autism, I think you all have a really big role in influencing and thinking about that and promoting that. And I'd say don't underestimate that. You know, you championing really good care is a really important thing. I think talking about this is a really good thing. And championing it forward. We're sharing it with others. If we get good care, if the basics are done well, whether it's in communities, it's in care homes, it's in people's houses, it's in the NHS, it will undoubtedly save lives. And if you can share, if you can promote, if you can recognise the challenges and support us in the advantages of prevention and things, that's incredibly helpful. Okay.
Thank you very much for that. I mean, it really is an important area for anyone who's got family members or have friends with family members who are severely autistic or have learning difficulties. The one thing that you end up doing a lot of talking about is actually their care, particularly when they are adults, and how carers and the system effectively, particularly the health system, how it actually supports their needs, particularly where they are quite often complex needs. And, you know, that's why it's so important to get it right. And that's why this report is really important, that people actually see it and they actually understand the context, because when they come across then somebody who will be included within this area or have family members who are, then they need to understand how critical it is that we get these things right. One of the questions that I had in particular, and is flagged a couple of times in the report, is the widespread misuse of the Mental Capacity Act. And the fact that that's referenced clearly makes it a concern for you. And it's not explicit in what way it's being referenced within the report, which I suspect is probably maybe for complex or good reasons. But I just wondered if you could actually elaborate a little bit about what those misuses are, so we can actually understand that a little bit more.
Yeah, absolutely. So we're getting lots of very rich information from the reviews, as you can imagine, and we've particularly picked up a theme around the Mental Capacity Act, and that's often around decisions around medical treatment and medical interventions. So as a result of this learning, we have quite a lot of comprehensive action plans that we have in place that we take back into our organisations. So I lead on that for the County Council and the Care Pathway. So some of that is around training for our staff around MCA and kind of awareness raising around that.
Okay, thank you. Mrs. Newson.
I noticed that the review service is not yet completed, and I wondered, when the review is completed, can you bring back a further report with more information if possible? Thank you.
Yeah, absolutely. And the more we talk about it, the more we bring things back, more than happy.
Thank you very much. Mr. Bannister.
Thank you, Chairman. The phrase widespread misuse of the Mental Capacity Act sort of leaps out, and of course it's repeated a number of times. And thank you for your answer in relation to that. But just as a follow-up, are there any legal consequences that may emerge because of any misuse of the Mental Capacity Act? My second point in relation to the report and the excellent annual report that follows on, and I really appreciated all the detail about that. I appreciated all the learning points that emerged and the positive practice. But again, I was struck with, out of the 83 deaths, the 70% were male. And I just wondered whether that what sort of lies behind that, and is there any need to address quite a significant imbalance in terms of gender that's being affected by the deaths?
So in terms of legal implications around the mental capacity decisions, so sometimes as a result of somebody's death, we may be undertaking a safeguarding inquiry, a Section 42 inquiry under the Care Act. That may take us down certain paths where we've got concerns that mental capacity hasn't been addressed. So we work very closely with our colleagues in safeguarding and the police and the Adult Safeguarding Board in those situations. Lots of people that we work with learning disabilities particularly might be in a setting that requires them to have a deprivation of liberty safeguard as well. So that's an assessment that's undertaken that will take restrictions to the Court of Protection to have sign off. So I suppose there's quite a lot of different legislative frameworks that kind of can sit around mental capacity and should be there to support people.
And building on that and coming to your second question, there's a real challenge about making sure that care is appropriate. So there can be an underuse of things, but there can also be an overuse. So there could be an overuse of Mental Capacity Act because you assume that somebody with a learning disabilities doesn't have capacity when they do have capacity. We have also, when we were very, very aware during COVID of being really clear about the prevalence rates for do not attempt resuscitation for this community group. And again, there were a higher prevalence of do not attempt resuscitation than you maybe expect. So the challenge for us, I think, in community and society as a whole is we're understanding an awful lot more and we're moving on a journey, but we have some inherent things to move away from. And making an assumption that somebody with a learning disability and autism doesn't have capacity, doesn't want to be resuscitated and so on, to actually people need to spend time talking to people. And we're on a journey of moving that forward. There are some really, really good examples of it. I think Leader Report will always keep picking up some of the deaths, the issues, the ways of going forward, but it gives us really good food for thought to keep talking about it. On diagnosis rates, prevalence, historically and now, diagnosis for learning disability and autism has a higher diagnosis rate in men than it does in women. It doesn't mean the prevalence in women is less. It's the identification in men's been higher. There's an awful lot of actually sort of looking at how stuff emerges through schools. Quite often young men, boys are far more outward, far more challenging in a school behaviour. Young women with autism particularly will mask and will be far quieter and far more withdrawn, I suppose. Now, that quietness isn't necessarily going to generate a referral from school and identification from others. So there are differences in how diagnosis has happened, which we'll see coming through to this, but absolutely things we've all got to work together on.
Thank you, Mr. Johnsworth.
Yeah, just a quick question, and forgive my ignorance on this. The pie charts were useful in terms of screening and those procedures. Are they much worse than the general population? And in dealing with the general population and getting them to attend these sort of things and perform them, do you apply the same principles, or is it a completely different set of principles in dealing with adults with learning difficulties?
In general, it's about reaching out and providing more opportunities for people with adults with learning disability and autism. So for me, at my age, I am entitled to an annual health check on the NHS once every 5 years. The logic behind it is good bit of screening for me, but if I've got anything else, I'll come forward. For adults with a learning disability or autism, one of the things we recognise is actually often got lots of other added health complications, and so annual health checks are offered on an annual basis. And an annual basis to try and make sure that means we're having conversations with people once a year in order to get them. So it's the same check, but the frequency is increased for people with a learning disability or autism.
Just coming back there, I mean, if a GP or the doctor thinks there is an issue that they're pretty certain of, how do then they take that forward against a reluctant individual?
So there's so I suppose there's a number of different bits in there. If they're so individuals, I suppose I'd probably go two bits to think about. I'd probably go, rather than being reluctant, think about an individual not understanding the consequences, not being aware of the wider issue. So if we meet people a minimum of once a year, then we can refer in, we can help get people support. We do employ learning disability nurses, we work with UHL and others to really prep people up to be aware of how do you deliver services differently, how do you make sure you've got extra time for people who need it, how do you find ways of working. I think the only other bit I'll just flag to you, which is quite important for this population, is we're working very carefully with GPs in primary care to make sure that if people don't attend, we record the reason for not attending. So we tend to just talk about people not attending as did not attend DNA. One of the options that you got within the systems we use is was not bought. And I think was not bought is a very important indicator for somebody who requires to come here by a care provider, a family member, rather than a do not attend. And it's really important we get the information about the difference, where did not attend is an individual not coming, was not bought, maybe that the care provider actually had too much going on that day, didn't have the staffing or the resources, so the travel out of that individual couldn't happen. And that, I think, is really important. So we're really trying to do that so that then we can really understand the challenges that people are facing. So I hope that sort of adds a bit of richness to that.
That's very good. Thank you very much. Look, we've had some good questions, and it's a really, really good report. Hopefully we can get an update, as Mr. Newton said, particularly where the preventable deaths have been flagged. Obviously, that's something that you and your teams will be focusing on, and on page 31 of the main report, there's obviously a sort of a change in program as to hopefully trying to reduce those numbers. So it would be great to actually get a feel for hopefully direction travel and whether it's actually made a significant impact on those preventable deaths. So that will be very, very welcome. Otherwise, we do look forward to seeing you again for the annual report. Is something that as I said at the beginning, it really does make a difference for those people who either family members or friends with family members who fall within the remit of leader, because the stress and strains of making sure the system actually supports their needs as effectively as possible is really, really important. So thank you very much for coming and talking to us. Thank you. Okay, look, we've got a couple of other items left on the report. Item 11, noting the work programme of Leicester, Leicestershire and Rutland Joint Health Scrutiny Panel. You've got a note of upcoming items, so hopefully that's for information only. Date of the next meeting, item 12, we have as Wednesday the 6th of March, same time at 2 o'clock. And then item 13, are there any other items? There certainly are not. So in which case, we close the meeting. Thank you very much for all of those attending. Thank you.